Hi, everybody. Welcome to our main final topic in terms of drug lit and research evaluation methods. And we've made it to the top of the pyramid, meta-analyses and systematic reviews. So let's get our feet wet in what is the pinnacle of the evidence hierarchy. So we're going to look at what are the differences between a systematic review and meta-analysis. We're going to be able to interpret some of the required components of a systematic review and meta-analysis, such as a Prisma flow diagram, and then figure out how are they actually including studies, because all systematic reviews and meta-analyses are done off of existing literature. So everything that's already been published. It's a new study in one way, but it's not, because it's using published data generally. And finally, evaluate visual data. So how do you actually look at meta-analysis output? You need to know this, how to look at forest plots versus funnel plots and things like that to know if there's an actual treatment effect, if there's heterogeneity, which is a type of bias, or other potential publication biases. Now here's the clinical scenario or dilemma we're going to think about today as you learn about systematic reviews and meta-analyses. And this is the Vioxx case study. Vioxx, now this is getting older, but it's a very famous drug that came out and ended up having really nasty side effects, like heart attacks, and got pulled from the market, and they got sued. And I think it's the biggest ever settlement from a pharmaceutical company. You'll have to look that up, but it was quite the scandal. So here's a scenario. You are an internal medicine pharmacist. You notice a concerning pattern. 5 patients have experienced heart attacks shortly after starting Vioxx, which is rifaxiba, which is a type of COX-2 inhibitor. When you raise these concerns to your medical team, they reference the phase 3 trials showing no association between Vioxx and increased cardiac events with a relative risk less than 1. So you're like, I don't quite believe this. So I'm going to go in and do a little more searching. You look in the literature and you uncover recent RCTs suggesting a significant increase in heart attacks with Vioxx, an RR greater than 1, and a p-value less than 0.05. So not good. So this is your clinical dilemma. What do you do with these contradictory findings from multiple high-quality studies? How should you go forward navigating this evidence when you have what's gold standard of studying a drug and its effect having opposite outcomes? How do you figure that out? And lo and behold, systematic reviews and meta-analyses specifically are the way we do this. How does one actually perform a systematic review and meta-analysis? Well, it really starts with the research question. So, does Vioxx increase the risk of heart attack? And then you perform a very structured, generally pre-specified search of the literature to identify all the appropriate studies. You don't want to miss anything, because then that creates bias in your systematic review and meta-analysis. And then if you can go beyond a systematic review and actually do a quantitative synthesis of the data. And so that's a meta-analysis. And then you have to do some validity assessments to look for how good were the studies, what bias are available, how reliable are your meta-analytic results. And as you can see here, we've reached the top of the pyramid, or the top step for hierarchy of evidence. Systematic reviews and meta-analyses are considered the best because basically they are a method to combine, mostly done on randomized control trials, but you could do systematic reviews on non-randomized trials. But basically combining all the evidence that's currently available to give you a better idea of the average effect across studies. Systematic review is the gold standard because it's using a highly structured process for finding and identifying existing studies that address your research question. And so it basically summates, or it gives a good summary through rigorous methodology to help eliminate biases that may be in individual studies, but when you collect everything together, it helps eliminate those biases and give a more clear, precise estimate of what's happening. We generally want to apply them when there's lots of really strong studies that exist, so randomized controlled trials that don't have hugely different effects, but they can have some differences there. And so it helps identify what is the average effect and the magnitude of effect as well, especially when you have lots of smaller studies, maybe in harder to conduct studies. And finally, a systematic review can either be qualitative in nature, so that's usually when you see in PubMed just systematic review. And so you're just doing a narrative, meaning in written words, saying what are the outcomes from all the studies and maybe what are some commonalities and differences there. And that's not as high quality as having a quantitative synthesis, which is the meta-analysis part of a systematic review. And then you're actually pulling data from all the papers, the means and the standard deviations or the interquartile ranges or whatever they report in their study. And then you combine them mathematically to give you an average effect or a precise estimate across all studies. So those quantitative syntheses really just pull those data together. Okay. They can make comparisons from multiple studies from different parts of the world to draw better conclusions because you're getting more data, you're getting more patients combined together, so more statistical power to make a more precise estimate on whatever you're looking at. But there are some limitations to meta-analyses, of course. So meta-analyses are basically restricted to whatever data you can find. You generally always want to try to email the authors. I've done meta-analyses and you try to ask for data, but almost never do they actually respond to your email to give you like this mean and standard deviation for this group. You generally have to work on the data that's reported in papers. And nowadays, they're getting better with more and more data being reported, especially in supplementary information. But that's certainly a limitation, so incomplete data reporting. And you're beholden to whatever population or inclusion-exclusion criteria were applied to a given individual study. And then when you're combining them together, you might have slight differences across your studies called heterogeneity, which might bias the results. So those are some limitations to meta-analyses that we always have to think about. What's the step-by-step process look for a systematic review? First, you always have to define your question, right? Does Vioxx increase heart attack in adult patients? And then you have to establish the eligibility criteria for what studies you're going to include in your systematic review. So you can use the PICO, TS, PCOTS framework to do that. And then you do this all beforehand. You have to say what literature you're going to search. So usually you're looking at, Medline, PubMed, Embase, maybe Cochrane reviews to see if one exists already. Maybe you're doing updated meta-analysis. Maybe you need to look at PsycInfo if you're doing a psychiatry study. However, generally, some people use Google Scholar, but Google Scholar is a little messy. Generally, you're going to get most of your studies out of PubMed because it's pretty comprehensive. But reviewers always want to see you looking at least 2 databases to know that you've cast your net wide enough to actually get all the appropriate studies. And then you have to go ahead and screen all those studies. So you can use, at Wayne State, we have Covidence. This is a software where you can actually upload all your search results into it, and then you can screen based on title and abstract. And so you can have, depends how wide you cast your net, you can have 3,000 studies, 10,000 to screen. I've done that too. And usually this is done by more than one reviewer so that you can tell their differences or mistakes there and rectify those. You search the references lists of the ones that pass that screening step. And so the reference list is called the so-called gray literature. So you're trying to identify studies that maybe didn't pop up in your search if your search strategy wasn't good enough. And then finally, you're going to go ahead and extract data and rate the quality of the studies. So you usually create these big tables, one for each study that pulls out the population information, average age, maybe the dose of what that was used for your treatment. Maybe you want to include something about the funding or the side effects. And then, of course, the outcome that you're interested in. And then you also want to do some sort of quality review. There's many standardized survey or tables that you have to apply to your included studies out there. There's Cochrane risk of bias survey. You just basically ask questions on each study. Did they randomize? Was it blinded? Did they give a power sample size calculation? All these things you ask for each individual study, and you have to do that for all of them and then report it. And then you synthesize the findings. So whether you're doing qualitative or quantitative you have to do that, and then you have to actually put it in a paper and report it. Let's take a look at what these steps actually look like, maybe applying a little bit of our Vioxx example here. So first you got to, we're asking the question, we already asked that, and then we have to determine what our inclusion-exclusion criteria are based on PICO-TS for searching the literature and including the papers we want to include. So maybe we want to include randomized controlled trials that are at least 6 months, that at least have 100 patients, and the outcomes we are specifically looking at are heart attacks would probably be the primary outcome for our clinical dilemma, but we're going to look at mortality too in hospital readmission. And then we go ahead and systematically screen all the studies that we've found from our searches against that criteria, and then we have to do data collection. So we basically extract from each individual paper, and usually you have 2 people do this because you don't want to make a mistake, because again, that's going to skew your findings. You might extract study design, setting, eligibility criteria to make sure you're actually including the right studies. What about population characteristics that might make the studies have different outcomes, intervention details, outcome measurements, all these things you want to include in your systematic review and meta-analysis. Systematic reviews actually have these guidelines called PRISMA, which is I believe it's preferred reporting in systematic reviews and meta-analyses. Basically, they're a set of guidelines that you basically have to have when you perform a systematic review and meta-analysis, and they have like checklists, and reviewers want to see that, or journals want you to upload the checklist when you do it. So it's very stringent. It has step-by-step checklists that you have to include throughout your entire systematic review and in reporting your systematic review. And what's the point? Basically, it's supposed to help you make sure that you've identified all the papers you need to identify. You're not missing anything, because then you're just reporting a pointless meta-analysis or systematic review and meta-analysis. And it increases transparency, so they want to make sure you're showing how you did it so that reviewers can assess it. And it also makes sure you go beyond just index databases if you can to find gray literature, although, again, this is very difficult. Do you include non-published data, so papers that haven't been peer-reviewed? Should you be including those? It's always a question that comes up, and most library information scientists would say yes, but I would say there's definitely issues with including non-peer-reviewed papers because they haven't been peer-reviewed, so how have they been validated against experts who have looked at it? But anyways, PRISMA also makes you include a flow diagram, which you see at the left. And if you look at it real close, you can see that it shows each of the steps of your systematic review. So how many records did you identify? How many did you remove that were duplicates? How many did you screen at the abstract and title level? How many did you screen at the full text article level? And then finally, how many did you actually include? So it shows reviewers step by step how you got to your final set of papers or data that you're including in your systematic review and meta-analysis. Going back to one of our previous lectures and the study about cannabinoid hyperemesis, this is just showing you what it might look like in an example, although I would say your search should be much bigger than this, but it's an example of what it might look like. And so this was a systematic review trying to look at, again, that capsaicin cream for cannabinoid hyperemesis syndrome. And the reviewers established the inclusion criteria that you can see at the bottom there. And so they found first 13 total studies. So they had a pretty stringent search criteria or search strategy. You won't ever see this in an actual published systematic review and meta-analysis. You usually see at least 500, if not thousands of records initially identified. And then they excluded, so they found 13. They excluded 6 because they didn't meet the inclusion criteria, which ended up with 7 studies in this systematic review and meta-analysis. Continuing with the hyperemesis example, there's actually been a paper on this, and so you can see what it actually looks like. So the authors found 214. We're looking at the PRISMA flow diagram to the left. They had found 214 records initially. They removed 50 duplicates. They screened at the title and abstract level 164, which removed 146. That left 18 for full text review. So again, you're looking at your inclusion-exclusion criteria at each level. Then they removed 7 more because they didn't have patient outcomes, which left them with a final study set, which is usually a big N, but here it's a little n, of 11 studies. And you can see some of the studies here showed in Table 1. Obviously, I can't include them all. And you can see they extracted data from them. They extracted the study design, what the patient's population type were, some of the history of bathing for systematic relief, what was the capsaicin administration strategy, et cetera, so forth. So you can see you have to create a standardized collection form where you fill in each of these columns for each individual study. And so this takes time. Some might think that systematic reviews and meta-analyses are easier to conduct. And in some ways they are, but in some ways they're actually not, because it takes a lot of time to pull out these papers and figure them out, get all the data out and all that, and make sure you're doing it right. So this is the step of actually pulling out the data from your final set of papers that you've included. One thing I'll say is that sometimes you'll see what are sometimes called opinion reviews, expert reviews in the literature. And so these aren't as favored anymore because there's no systematic component to them, but you'll still see them because there's certainly experts out there who can give you a wealth of knowledge without having to do a systematic review. But one of the defining characteristics of a systematic review is not only the systematic approach to identifying all the studies that are appropriate to your question, but actually looking at the evidence quality. So looking at the internal validity of it, maybe looking at a little external validity. And so we usually want to use something like the GRADE approach, the grading of recommendations, assessment, development, and evaluation. And you can see here in the table, it gives you essentially some examples of what that looks like in terms of the quality of the evidence, uncertainty about the balance between the groups, or the variability in the values. You're looking at all these across the studies to figure out basically how good the data is for the systematic review. So you're looking at the quality of evidence, the methodological rigor, clinical significance, bias, grading, and all these things help you figure out how good your studies that are included in your systematic review. It's not how good you did the systematic review. It's what the quality of studies that are included in your systematic review. Are they really high quality? Is it poor quality? That'll tell you how confident you are in your interpretation and assessment of the findings. We've looked at what the qualitative portion of a systematic review would look like, so that it would be that, again, that extraction data table we talked about 2 slides ago. It would be the quality review in the previous slide. Now, if you want to add a meta-analysis on top of it, quantitative synthesis, then you need to start collecting data from each study. You can see the example here with Vioxx and placebo. We have 2 studies. We want to know what the number of heart attacks were in each group, the no heart attacks, so we can calculate a risk ratio and odds ratio for each individual study, and then we can combine it in a meta-analysis. So we're giving a meta result, super meta, right? To figure out what the average effect is across all the studies, and that's how it's done. There's many different ways to do a meta-analysis. They certainly don't have to just be risk ratios and odds ratios. There's usually standardized mean differences. There's many different techniques. There's been entire textbooks published on how to do meta-analyses, but this is a common example when you're looking at a yes or no outcome for a given drug. How do you actually select studies for your meta-analysis? This is very similar to a systematic review, right? Because the meta-analysis is actually stacked on top of the systematic review. But you also have to think about things like outcomes. So you have to obviously think about the population that you want to look at. So that would be the PICO, okay? The P of PICO. Then you look at the intervention. You have to figure out, do you want all interventions, some with similar dosing, some with variable dosings? The more wide range you cast, right, the more heterogeneity or more differences between the studies that could affect your results. You want to make sure your outcome measure has fairly well aligned. So how did they determine, for the Vioxx question, how did they determine heart attack? Was it via symptoms? Was it via expert opinion? Was it via interventional cardiology? Things like that. And so you always have to assess all of this against your meta-analysis and your topic of interest, because you could certainly have many different studies included in your meta-analysis that might increase the kind of applicability across the entire literature, or you could be more specific to certain patient populations that you might be interested in. We've taken a look at many of the steps of a systematic review and meta-analysis. And basically, in the end, you have to be able to interpret and account for biases in a systematic review and meta-analysis. which is almost entirely dependent on what literature was included or what data was included in your systematic review and meta-analysis. So how internally valid is it? You need to be able to figure out whether the studies were analytical or descriptive, prospective, retrospective, all the things we've learned. That'll help you assess whether you have a really strong meta-analysis or maybe you have a weaker one, which might give you some information but has some caveats when you're interpreting the results. Here again is just a review of systematic reviews, finally the process and validity. So again, the validity is going to depend on the underlying quality of the studies that are included. And the same is seen for meta-analyses as well, even though they do have some statistical outputs that'll help us assess that quality. Again, it's going to be all dependent on the underlying studies that are included in there, but we get some additional data like what are the precision of the estimates from the pooled studies that account for study size and the precision of the outcome estimate. So those types of things also help you understand on the meta-analysis level how good it is. With the meta-analysis, you actually kind of roll in some of the underlying quality of the studies into your estimates. So here we can see with nominal variables, which is either you have it or you don't, right? It's a 1 or a 2, 0 or 1, whatever you want to call it. Nominal variable, yes or no. And so with a meta-analysis, it's usually weighted. And the weighting usually takes into account the sample size of the study and how precise the estimate was within that study. And you can see an example here of 5 studies, all with relative risks, okay? And they get different weights depending on the sample size and precision of their estimate within each individual study, which then is used to calculate the pooled estimate or the average effect across all studies. And you can see the weight equals 100, and then the pooled estimate is 1.22, which is not an exact average of the relative risk because it's weighted for each study. And then you can get even more information to the right here with the pooled risk ratio of 1.22. You get the confidence interval where you think the true estimate lies for all those included studies. So it's still above 1, right? So it would be statistically significant, which we see there. And then finally, we're going to talk about heterogeneity, but heterogeneity refers to how similar were the studies, the underlying studies statistically. And the higher the heterogeneity, the more bias that's potentially there and the less confidence you have in your reported pooled result. The same type of procedure is used for a continuous variable, okay? So something like blood pressure or cholesterol levels. They still use some sort of weighting procedure that depends on the sample size and the variance of each individual study's estimate to give you the pooled estimate. So you can see here the mean difference is a negative 2.67, so it's decreasing when you combine all the different studies, and you can see the calculation there, which uses weights. You can see the 95% confidence interval goes from -3 to -1, so it's still less than 0, so it would be statistically significant. The p-value corresponds to that, less than 0.001, and the heterogeneity for these groups of studies is slightly lower than the previous slides with 38%. Still probably moderate heterogeneity though, because it's near 50%. In virtually all meta-analyses, you will always see a forest plot that represents the combining of the statistics from each individual study. And a forest plot just looks like a bunch of different little trees to give you the actual pooled estimate, which is generally a big triangle. So you can see that in the picture there. You can see each line represents a different study. The square is the study, which the size of the square represents the magnitude of effect, which you can also see from the tails on each individual one. The wider the tails means the less precise it is, okay? Like the third study down has really long line and a tiny square, which means that it's highly variable. The variance in the estimate was really poor, okay? Probably a small sample size. And all those individual squares are put together to give you the pooled estimate or the meta-analytic result, which is that giant triangle at the bottom. This is something you need to know. You'll see forest plots all the time. And the actual picture there always corresponds to all the statistics to the left. And so you can see overall at the bottom of that picture, it says overall, which is the pooled estimate is -3.26. Okay, so again, the variance or the confidence intervals are those long tails on each of the squares, and those are all used together in the weighted calculations we just talked about to give the diamond not triangle, did I say triangle earlier? The diamond or the pooled estimate for the overall effect across all the studies. Let's take a look at a forest plot example with a nominal meta-analysis. So nominal being yes, you have the event, or no, you don't. So in this example, they were looking at the use of prophylactic aspirin in diabetes patients and seeing if those patients experience more bleeding versus those on placebo. So you can see each blue square in that figure at the top represents a different study. So we have 3 studies in this meta-analysis: JPAD, PAPADAD, PPP. And each study has an effect estimate with an odds ratio, and then the variance or the 95% confidence interval is the tails on it. So you can see in the first one, JPAD, you can see that the effect is probably the second smallest of the 3 studies, and it does cross 1. That tail touches the 1, meaning there's no statistically significant effect. And you can see that in the odds ratio, 3.06, and the 95% confidence interval goes from 0.98 to 9.50. The second study, PAPADAD, has a bigger square, and you can tell that it has a larger, more robust estimate of the effect because the 95% confidence interval lines or the variance are very small. But that one's also statistically non-significant between aspirin and placebo, suggesting no increased bleeding from aspirin. And then finally, the third study is really small square, which suggests that it's not very precise. And you can see that from the statistics right to the left of that for the PPP study, where it says 8 is its estimate, favoring placebo. However, the 95% confidence interval touches 1 and goes from 1 all the way to 64. So it's huge. So that doesn't really tell us much. That's where the pooled estimate now comes in. That black diamond takes all 3 different studies using that weighted calculation we talked about a few slides ago and shows us that the pooled estimate is about 2 favoring placebo. However, it crosses 1, it goes from 0.63 to 7.33. Therefore, it would be statistically non-significant. We see that on the test for overall effect, p equals 0.22. We also can see the heterogeneity. The I squared there, that's heterogeneity, is 72%, suggesting that these studies are really different. There's something happening between the studies, and we'd have to look at the extraction table 1, for example, to see maybe the populations are different, maybe the age is different, maybe the sex is different. Something is driving big differences between the studies here that make our estimate, our pooled estimate, less reliable. So basically here, we would say in the interpretation that there's no significant increase in bleeding with aspirin versus placebo in these patients, and therefore perhaps it's still a risk versus benefit if you're doing a clinical application, but we would still have to figure out what increases one's bleeding risk and whether it's worth it, maybe on efficacy or whatever you're trying to prevent in the outcome, since this is looking at side effects. Now, meta-analyses always have the limitations we kind of briefly mentioned earlier, publication bias being one of the biggest ones, because journals always or generally always want to publish something that has a result. They don't want a bunch of negative studies because people don't look at negative studies, they don't click on negative studies, they don't buy their journal articles with negative studies. So investigators are more motivated to write up positive studies versus negative studies they might just leave in the drawer and never actually publish. Heterogeneity, as I keep mentioning throughout each of the slides, reflects the variation in results among studies included in meta-analysis, and these can be driven by differences in study populations, age, sex, comorbidities, or maybe differences in study designs or intervention components. And so when you find high I-squared or heterogeneity, you have to go back and compare the studies carefully. And there's actually ways to control for it in a meta-analysis, doing either sensitivity or sub-analyses or meta-regressions. You actually can do a regression for meta-analysis to see if your outcome still holds while looking at some of these different variables between studies. How do we actually detect publication bias? One of the main ways we do it is through a funnel plot. You can see there's a funnel plots. There's 4 of them there to the left. And they basically look at publication bias because there should be a natural variation around the midline of the pyramid, kind of in the upper right one. There's kind of natural variation, probably not much publication bias. Versus, you can see in the upper left one, there seems to be some publication bias because there's a lot of effects to the left of the line versus the right of the line. So something that you need to interpret or think about when you're interpreting the results of that meta-analysis. That's basically called asymmetry. Okay. And you can also do further testing like Ager's test, and there's other fail-safe ends, and we don't need to go into those, but they will show you what the likelihood of studies not being there will bias your results or make your results negative. Okay. So you can see up there, again, in the figure, it shows 4 funnel plots. The first funnel plot shows asymmetry, which you can just visually see. And then the Ager's test, which is put on top of the funnel plot, is statistically significant. So you would expect that just by visual searching of that plot, but the statistical test helps objectively confirm that, suggesting strong publication bias. However, the other 3 don't really show much publication bias based on visual inspection and the Ager's test. Here's finally the slide on how do we assess heterogeneity in a meta-analysis. As I've been mentioning throughout this lecture, it's that I-squared statistics, okay? So heterogeneity can range from 0, meaning there's no heterogeneity between the studies, to 100%, meaning that there's really high heterogeneity. Okay, anything above 75% is considered substantial and calls your result into question. You can also do a statistical test on the I-squared value to tell you basically whether it's statistically significant. We always like to do that. You can also look at visual assessment of the overlap of the confidence intervals. So are they really similar? Are they really wide-ranging? Things like that will help you assess heterogeneity. And this will tell you about whether or not you should be pooling your results. If you have a really highly heterogeneous set of studies, should you really be pooling them? You can, but you should at least be doing further meta-regression or subgroup analyses to explore or explain why the heterogeneity exists when you're reporting your results and interpreting your findings. Sometimes heterogeneity is actually useful when you are looking at your overall result because you're saying, whoa, there's huge differences in these studies. Like you can see in this example in the upper left picture, some of the studies have really precise estimates. Some of them are huge. And so that's where subgroup analyses come in, because you can actually then tell a story about, well, in these set of studies, looked at this specific patient population, or maybe this type of intervention dosing or whatever it might be, we see much more significant results versus in these imprecise studies in this set of patients, it's not statistically significant. So doing those subgroup analyses will help you to understand the pooled effect and whether or not it's more applicable to certain subgroups, right? High versus low disease acuity patients, different demographics, males versus females, or maybe different previous medical histories. And it'll tell you whether or not your treatment is more applicable or more useful or has more side effects, whatever you're looking at for your outcome in various subpopulations. All right, to wrap up this lecture on meta-analyses, systematic reviews meta-analyses, you should be able to really understand what a systematic review is, how it's performed, what are the differences between a systematic review, meta-analysis, and narrative review, how you actually look at some of the visual interpretation of a meta-analysis, specifically funnel plots and forest plots. And finally, how do you look at some of the limitations in a systematic review meta-analysis, being careful to search for bias and other things that we should be aware of when interpreting results. And all of these will be used, we will apply them in class, and you should be aware of them. You don't have to do the actual statistics of a meta-analysis, but you should be able to interpret given statistics from meta-analysis. Thank you.